joining a few housekeeping items that should be helpful is that if you get kicked off the distribution list, please let us know. Dr. Cowgill apparently was just removed from the distribution list, which was not my doing. So if you realize you haven't gotten any kind of email during the month, even if we cancel, I'm pretty good about sending emails to say that we're going to cancel. So if you haven't gotten anything within a month, always check with me, and we can add you back to distribution lists. It's just, I still don't know the mystery that Outlook does. Right now, it's going to like about 110 people, and I'm wondering if sometimes it just gets filtered out. So
I took it very personally.
Sorry. Well, one time Jessica Hokamp wasn't on for like 2 months, but because we text every day, she knew when to join. And then I realized she wasn't on the list. So it does random culling, I guess, of the population. That sounded really pathologic, and I apologize for that. So that's number one for housekeeping. Number two is that we will double check, because as we get into November and December, sometimes it overlaps with Thanksgiving, since that week, but I think actually this year we might be fine. Would be the 21st, and it looks like Thanksgiving is that following part. So I think we should be fine for November for hosting this as well. We do only host rounds when there is a case request, and I usually have enough kind of filler material to do at the end, so it doesn't always have to take a full hour. Thank you for our volunteer. I think you were being voluntold by Dr. Foster. He is currently traveling, but it actually is good discussion for us to realize what we can do to manage these cases. And I want it to be pretty clinically oriented, and have the pathology be a supporting framework for the discussion. Speaking of pathology aspects of it, Dr. Hokamp is currently away from the office for personal reasons. So if you have submitted SDS pages and are desperately waiting for results, she is working as hard as she can to get those done from a remote location. And so she told me to tell you guys, if there's anything that's specific, very urgent, you can email her and she can try to triage it to the front. But she is helping her mom. So she's not in the office. And so she asked me to tell you guys, she's working as hard as she can, but if you have something you really need the results on, then please let her know and give her a heads up. Yeah, so I think that's the housekeeping stuff. And Dr. Elias has joined, so I feel like we're a good complement now. And we're going to discuss one case today for a bit, and see what we can do. I'm going to say the pathology still is pending the electron microscopy. And it doesn't actually have a great outcome, as from what I've heard. So everybody be ready for a negative outcome, I guess. But the diagnosis is pretty clear cut even without the electron microscopy at this point. So it's kind of why we're at a pause there. So I think you should be able to share, Dr. Skinner.
I didn't make anything to share because
Oh, okay. No, that's right. Yeah. Then you should be able to just keep talking. I'm going to mute myself.
Perfect.
And yeah.
What you wanted.
And we are getting blood pressure on another patient, so you might hear some beeping in the background. But okay, so the patient I was going to talk about today is called Chimuk. We don't have a lot of history on him. So he was a 4-year-old male neutered Peruvian Inca orchid, which, if you look it up, is like a medium-sized hairless dog. He was truly from Peru. As far as the owner knows, he was like an apartment dog while he was there, and she adopted him in August of this year. He was neutered right before she adopted him, but otherwise we don't really have anything on his previous history. So when she picked him up, clinically, he was very cute. He had a lot of comparisons to a cow while he was with us. But he went to his first wellness visit with his primary veterinarian at the beginning of September, like I think September 14th. And already from that visit, the owner was like, yeah, we're here for vaccines, but also we've noticed like a little bit of swelling in his back legs, which he didn't have when we first got him. The primary vet did get a pretty good start on baseline diagnostics. So at that point, he had a normal CBC. He was not azotemic. His creatinine was 1.4, BUN 22, but he was hypoalbuminemic. His albumin was 1.8. And he did have 4+ protein on a urinalysis and too numerous to count granular and waxy casts. They ended up starting him, I think, on like doxycycline, and then brought him back for a blood pressure the next day, which was high at 180. Yes, he had a normal CBC. And then the RDVM started him on kind of a weenie dose of enalapril. She put him on like 0.13 mg per kg once a day. And then brought him back a week later. I think they were using like a mobile ultrasound to get an ultrasound done of him. So between the 14th.
Sorry, what was his creatinine at that time?
It was 1.4.
Okay. And is he pretty small?
No, he was like 20 kilos.
Okay. Oh, okay. He
Yeah.
looks small in the picture, but I guess it's because it's a picture.
Yeah, and his USG was 1032 at that visit as well. So he's actually concentrating okay. So a week after they noticed a little bit of the swelling in his hind limbs, he came for the ultrasound, and at that point he had marked bilateral pelvic lymphedema and moderate abdominal distension. On the ultrasound, they noted diffuse hepatopathy, bilateral renomegaly, and peritoneal effusion, and recommended that he come see, because it was like a mobile internist, so recommend he come to like an actual hospital. So he actually came to us the same day that he had his ultrasound. And so a week after his initial blood work, his CBC was still very static and normal, and his chemistry was also relatively static. So he remained non-azotemic. His creatinine was still 1.4. His albumin was a little bit worse when we saw him. It had dropped to 1.4. And he also had elevated cholesterol at 324, which is 4 points above our reference interval. We found that he was not hypertensive when we saw him, but he was also on enalapril at that point. So he transferred to me the next day, and he did look like a cow. He's like a black and white spotted dog, and he had pretty marked abdominal effusion. His pelvic limbs were very edematous. He had like, he was neutered, but he had scrotal edema. He didn't look like he was neutered. He had perputial edema. He was very full of fluid. Despite all of that, he was very bright. He had a voracious appetite, and was not having vomiting, not having diarrhea, anything like that. So we did recommend.
Was he getting fluids? I mean, treatment-wise, it sounds like you said he only had like a little bit of enalapril on board, but he also wasn't getting like overhydrated, was he?
Okay. No, he didn't get any fluids from the RDVM. And when he came through our urgent care, we also told him to not start any fluids.
Got it. Okay.
So we did end up, and then I guess of somewhat unknown importance on his physical exam, he did have these somewhat unusual like lacerations that the owner said had actually been there since she'd gotten him like 2 months earlier. So he had this laceration horizontally across his abdomen that the owner was like, oh yeah, that's from his neuter, but someone really messed up if that was his neuter incision. And then he had like a scabbed area on his ear. So he just seemed to have like a couple of kind of poorly healing wounds. But by the time I saw him, they were seemed to be on their way to healing. So that morning we got our ultrasound guided renal biopsies, and given that he was kind of meeting all the criteria for nephrotic syndrome, we did end up starting him on prednisone and mycophenolate that day.
Okay, we can, are there questions about clinical stuff? And I guess, so he's from Peru and they just adopted him. They adopted him or they bought it? Like there's an adoption service from Peruvian dogs to America?
They did, it seemed like they truly adopted him. Like he was a 4-year-old dog and came neutered. But I didn't have any of the paperwork from either the agency that brought him to the US or anything prior to coming to the US.
Yeah, I remember reading that and being like, so oftentimes we it sounds like a couple of months ago.
I used the
Go ahead, Becca, were you asking a question?
sorry,
Oh.
intending to be on mute. Sorry.
No worries. So yeah, I do remember reading this breed and being like, I've never seen this breed before, and then having the note that it actually was a dog from Peru, and I was very I was like, oh, I didn't, it's for some reason I assumed that he was like a very specific breeding dog that they had brought, but it does sound like if he came neutered and he was from was an older dog anyway, he was truly adopted. So okay, so I need to make sure I have the right thing set up to show you guys the lesions. So we got the biopsy. They were excellent cores. I know that we do have always some questions about quality of biopsy and how many glomeruli do you need to have for the biopsy, et cetera, et cetera. So just show you guys the amazing cores, which I think I just need to do this. Hold on one second. Make sure I can do that. Yep, perfect. What I guess my impression of being able to do excellent biopsies is being at a place that can train you to do excellent biopsies. So we always get great biopsies from Friendship, just because they have had a lot of practice. So I guess if you think about practice makes perfect, this is an example of that, where they always get a really great core. For the pathologist in the room, when you're visualizing what a core should look like, it really honestly should kind of be limited to the cortex if possible and be going along the long axis of the kidney. So I don't actually know how the needle would be oriented because I'm not in the biopsy room, but I envision it kind of going cranial to caudal along the dog's or cat's body wall to catch the cortex and get a large number of glomeruli. You can see here, we're probably like close, getting near where the corticomedullary junction is, because we've got probably an arcuate caliber vessel right here. It is fine to go through those. They seal up immediately. We don't have any negative outcomes when you see more arcuate vessels. We do advise people to try not to get the medulla. Mostly that's because the medulla really isn't all that informative for a lot of our cases. So usually it's just because it really doesn't help us. But you could probably lacerate a larger vessel if you go through the medulla and you get kind of where that renal artery branches. So histologically, we had a pretty normocellular glomerulus, and I will show you the PAS, which is our favorite stain to look at cellularity. And I'm 99% sure this is one where JD texted me and said, could you look at this quickly? I'm worried he had amyloid just because of how edematous he was. And so I was actually not even at my computer, and Dr. McClellan was able to quickly log on and say, hey, this is an amyloid, just to at least give you guys that piece of information. It's something else. She said, and she kind of texted me and she said, I think it's going to be, well, she called it, I'll tell you that. So I'm not gonna ruin the diagnosis for everybody, but just even looking at this, she was able to say, I'm pretty sure it's going to be one of these kinds of diseases. So we have a chat question. Mark Dedema. Oh, okay, yes. Oh, wait, one new message. Pigment in tubules related to hepatopathy if the biliary, but that's a good question, Becca. We have a lot of people that ask us about the kind of gold brown pigment that happens in proximal tubules. I have never been able to associate it with anything. I've seen it in cases that have increased tubular cell turnover, so it kind of almost looks like it could be a steroid type product. I've never actually done a huge study where I've stained a whole bunch of kidneys to identify what the pigment is and whether it's not bilirubin or not. If when I see orange, really chunky tubule or pigment within the lumens, then I know that there probably is something going on with the liver. But in general, that's pretty uncommon. So I haven't really been able to say, yes, that's definitively associated with hepatopathy. I think we have a few clinicians who are interested in looking at that clinically, especially with dogs that have maybe hemoglobin release or myoglobin release, and be able to actually stain that pigment. But I have not been able to quickly associate any kind of disease phenotype with the pigment in the tubules. Let's see. We got more. Okay, we have cats. Oh yes, Dr. Craig does have that thing. I think that they're talking. Is that one of the cases that it's going to be presented with the big cats? There might be some discussion about that at ACVP. So there's a lot of pathology discussion. I'm going to get back to the glomeruli. So I'm going to look at this glomerulus. I hope everybody is seeing a picture of a glomerulus that has a fairly normal cellularity. Like I said, I usually like looking at the PAS for cellularity. But I don't see, 4, 5, 6 cells hanging out within the capillary lumens. And then also looking at mesangial zones. So there really isn't that striking of a phenotype in the histology, the H&E section. And then we will probably go, let's click right through to get to the PAS, which is this one. Oops, hold on, gotta shift back. So the first two stains we always get from our biopsies are the H&E and the PAS because they're the quickest to do. And this is a little out of focus. I think we had to take multiple scans of the PAS. Maybe not. There are some, it's just a little bit blurry. So it's really, it's kind of frustrating to look at. So I'm not going to spend much time. But looking at mesangial zones, we have 3 nuclei. That's acceptable. 2 to 3 nuclei is fine. And then we have a lot of capillary loops that have a single nucleus right at the base. So that's fine as well. The next stain is going to be of immediate interest to us. So we're looking at the trichrome. And the trichrome is very in focus, which is excellent. And we have, again, that cellularity where here is our capillary loop. Hopefully everybody is able to see my arrow. So we have a good capillary loop and we have a single nucleus. Perfect. That's all we're allowed to have. And we have that in a lot of capillaries. And as I was kind of revising JKP, I'm a little behind the deadline. It's hard for me to say, what is your limit of cellularity on a glomerulus? We know what it is in a dog and a cat, and we're used to it. It's hard for me to say in other species what that limit of cellularity would be without actually having somebody go through and count cells. But it's also hard to emphasize that if you only have a single glomerulus that has a single capillary loop that has too many nuclei, that doesn't make your diagnosis of hypercellular. It has to be repeatable. It has to be identifiable in many capillary loops for us to say, oh, there's too many nuclei. So if on average, most of your glomeruli only have a single nucleus in it, that's good. If on average, most of your mesangial zones only have a single nucleus or 2 nuclei, maybe 3 nuclei, then that's fine. I don't really want any residents to like read JKP and then immediately start thinking they have to count every single nucleus within a capillary loop. It is kind of the overall impression. But the other overall impression I get from this particular glomerulus is that the podocytes are very unhappy. So our podocytes are sitting out here in Bowman space, and they've got very large nuclei. The nuclei are oriented towards the urinary space. Here's another one where his like nucleus is basically trying to jump off, trying to get into urinary space. Again, another podocyte with its nucleus up towards the top, trying to get to the urinary space. And that is an impression I get on a lot of podocytes. So if everybody is looking at all these podocytes and picking out, they're hypertrophied and they've got very large nuclei. Now, Shannon was really great because she picked this up, I think, even without the, no, she had the trichrome to look at. So she did find this on the trichrome. But you start to see there are a little bit of redness along the glomerular basement membrane. And so this is something she texted me. She's like, I think these are going to be really early immune deposits. And this is my presumption. If you look at this capillary loop here, we have like these little tiny red foci. Here's another capillary loop, a few tiny red foci. Now, I'm going to put my face on the screen so you guys can see when I'm saying this. If I can find a way to make my face on the screen, 1 second. Share my face, because I think this is important. I think that when we see these lesions, for those of us who see them commonly, like Shannon, myself, and now Sarah, and also Dr. Nabdi and Dr. Hokamp, we have this sneaking suspicion that those are going to be immune complexes. But we also have the extra information that this is a severely proteinuric dog. And we have this extra information, the podocytes are very unhappy. So I would never look at a capillary loop like this from an autopsy specimen that didn't have any history, didn't have any UPC data, didn't have anything. And I would not care. I would look at this and be like, whatever, it's probably nothing. But because they have so many pieces of evidence pointing me to the fact that these are probably immune deposits, there's red material on the capillary loops. This dog is extremely proteinuric. This dog is edematous. He has full-blown nephrotic syndrome at this point. And those podocytes are so upset and they're trying to jump off the capillary loops. That's when I am suspicious, strongly suspicious that this is immune complexes. So we texted JD and we said, we think this is probably going to be an early membranous, but I'm going to need the other pieces of information before I verify it. At this point, they'd already were suspicious themselves and had already put the dog on immunosuppressive therapy. So the last stain we haven't looked at is the Jones stain, which I'm going to go to next. And so the Jones stain looks at the glomerular basement membrane. And so when you have immune deposits, there is as we've already said, a disturbance of the podocytes. And so the podocytes, again, this one, you can even see them here. The podocytes are jumping off the capillary loops. Their nuclei are pointed towards the urinary space. And one of the responses over time, it takes time to do this, is to create new glomerular basement membrane material and lay that basement membrane material in between the podocyte, in between the immune deposits. And so you get these little spike-like projections towards the urinary space. This is so early that I don't think that's happened. We might have tiny little blebs, but really, honestly, the GBM isn't severely remodeled at this point. The GBM actually looks like it's pretty normal. So that tells me that this is probably early onset deposits. Again, I'm only using that piece of information knowing the time course of what happens in humans. I can't tell you would only be a couple of months to make the spikes, or whether it would need to be a year to make spikes. We have not really studied that. But the deposits are suspicious. They seem small, and we don't have a good GBM response at this point. So I'm pretty confident that this is probably something that has been early onset. We're in an early phase of membranous. So I think I even sent it out on light microscopy as suspicious, or maybe I just texted as suspicious membranous. And then I have IF as well. Does anybody have any questions? Oh, 27.7 was the UPC. And that was at the time of biopsy, Dr. Skinner? Okay. Any questions about pathology, histology? I don't know how many glomeruli this had, but I would say it probably had at least 30. It was a really good sample. But it's that's what look how many gorgeous glomeruli are there. Oh, I guess the other thing that I would say, which when I see these, and obviously we've given you a hint, it's not going to have a great outcome, but when I see these, I don't see a lot of scarring. This is not a shattered kidney. This kidney is not scarred. This kidney has a lot. I mean, if it gets rid of these deposits and stops being so proteinuric, this kidney is going to do fine. So that's kind of the scenario where when I look at the trichrome, which I think is the next stain, which we already looked at to see the deposits, there's not a lot of blue material in here. I don't see a lot of collagen deposition. If anything, there's just a little bit of interstitial fibrosis. The tubules themselves actually look pretty good. Remember that tubules need to have a smushed together lumen. They should not have a really good open lumen. These guys out here with open lumens are distal segments of the nephron, so they have more space in their lumen, but everything else looks like a great proximal tubule. You can see the brush border really well with that pale blue material. So this looked like a really good kidney. It just looked like it had early immune complex deposits. Okay, so I'm going to show the IF and then we'll go back to the clinical progression of the case, if that's okay. Okay, stop share, which means I need to bring up the IF. And if there's any questions, let me know. Come off of mute. How high was the blood pressure? Did you, I guess, yeah, how high was the blood pressure, Doctor Skinner?
It was 140 pretty consistently pre-biopsy. We did still send, and that we actually were not giving any enalapril when he was in hospital. So that was like a day off of his enalapril.
Okay.
And I think the ultrasonographers were not confident in their ability to call a lot of hemorrhage or not because of how significant his peritoneal and perinephric effusion was. So they're like, he could have bled some, but it could have been lost into the vast amount of fluid. His PCV was static the next morning though, pre and post biopsy.
And I think that's a good point. We do get a little I guess nervous when they are severely hypertensive. We've had from my most recent review of our database, we have had one dog die post-renal biopsy, and that dog was severely hypertensive. And then we had another dog that that have been reported to us. Obviously something could have happened and they never reported to us. But we've had another dog that had severe hypertension, was biopsied and bled significantly into the kidney, and they ended up having to do a nephrectomy because there was such significant hemorrhage. So the two negative outcomes that are identifiable from our standpoint were associated with severely hypertensive dogs. So I do get, but then again, I haven't done a meta-analysis to say how many hypertensive dogs have we gotten biopsies from where nothing's happened. So, but it would make physiologic sense that we would be a little bit, and it's taking forever for this to download. Okay, I'm gonna just pull up the report instead. I was trying to download the IF images. Instead, I will just open the report. 1 second. So immunofluorescence wise, let's see. Oh, it does not have a, oh, because this is the, I apologize. 1 second, 1 second. It is because I have not reported it yet. I have, or if I've reported it, I haven't, I did not save that part. 1 second. There's me. I'm going to tell you it's positive. I apologize for this. And I will go back 1 second and see. I think I just texted JD though, is probably what happened. Yep, I did just text. Okay, so it's just taking forever for this one thing to download. So let me go back and see if I can show it a different way. Okay, so I'm showing you the original images. It's just taking forever for the modified images, which tells you which label everything is. So we have great glomeruli on the in the IF core as well. So when the sample comes to our lab, or I should say the lab at Texas A&M, it's not technically my lab anymore. They get triaged by one of the lab staff who looks at it, tries to make sure that there are glomeruli that are going to all 3 studies. So you can see these little red dots in the cores. And so you try to make sure that the sample that came in Michelle's transport, so that's done at the time of biopsy, the clinician and the ultrasonographer is putting it in Michelle's transport. And so they look at it and they try to make sure, yeah, there's going to be a good number of glomeruli. So they have an estimate before they go through the IF. So sometimes they'll look at it, the sample that comes in Michelle's transport, and it'll look just like fat. And so they'll give me a heads up like, hey, this doesn't even look like it's kidney. So when we stain it, we're not expecting to see anything. But if they do get a really good core, then they will look at it and say, yeah, there's a lot of glomeruli. It looks like it's cortex. And so then I know when I'm looking at IF, I should have a lot of glomeruli to examine. And so it does kind of help me gauge what my number of glomeruli would be. They take photographs with their immunofluorescence camera. I do not have immunofluorescence at my house, but they send the pictures. So this is C3, and there is good granular staining, which is what we want. I wonder if I can get bigger. Yep. Granular staining is important. All these little dit dots along the capillary loops are consistent with the tiny little dots we were seeing on histology. So you can see these capillary loops are outlined by the immune deposits. Sometimes the deposits are so small, and it's kind of like in this case, where it almost looks linear. And so we will actually say it's pseudo-linear. Now I can actually open this up so you can see this one instead. That way it has it all labeled. It looks pseudo-linear, and that's why. I'm needing to stop share so I can share this other one. I apologize for this. It actually, what happened was it downloaded everything, which is why it was taking so long. Okay, so same picture, but now it's labeled so you know what you're looking at. So the term pseudo-linear can be used when the deposits are quite small. If you got very, very high mag and we had like, I don't know, 100x resolution, or maybe that you would actually see they do kind of resolve into their own deposits. The reason that's important is mostly based on the human disease, which is anti-GBM disease, and that actually has a true linear pattern. It's not pseudo-linear. And with the true linear patterns, then we get worried about different types of antibodies, and it's not truly an immune complex disease. Instead, it's an antibody that is directed against the glomerular capillary wall. We have never seen that in veterinary medicine. So anti-GBM disease, which is used to teach, I remember learning it when I was in veterinary school, has never actually been demonstrated in veterinary species. So it's important to distinguish pseudolinear and linear, true linear in humans, but from animals, we've never seen a true linear pattern. Let's see if I can go to the next one. Okay, so then IgG is gorgeous. Again, the dit dots, hopefully maybe I can go a little bit bigger so you guys can see the dit dots. It kind of resolves a little bit better with the IgG. So hopefully you guys are seeing that. Tell me if you're not. Oh, it says it's paused. Am I?
C3, still showing C3.
Hold on. Thank you. Because it was gorgeous. I know what I need to do now. I need to go to Zoom. It's hard when you're used to like working with like 4 screens and then going into a world where you only have a single screen. It's like the injustice of it all. Okay, Now you're definitely seeing IgG because that's what it's telling me you're seeing. So this is, you can see the dots resolve a little bit better with the IgG because again, these are true immune complexes. They are antigen antibody complexes. They are lining up along the capillary walls. Oftentimes, the best way to teach my trainees and the people who are interested in kidney is that you really do want to compare what's going on with the glomerulus to kind of like background non-specific labeling in the tissue, like the tubular interstitium. So it really honestly would be, okay, this is really strong. And the background labeling of just a normal random FITC molecule binding to the tubular interstitium accidentally is kind of weak. So being able to compare between the two of those is very helpful. If you had the exact same intensity between the glomeruli and the interstitium, then I would think something weird happened and it's non-specific binding. And we can see that. George and I have seen it a lot when the IF tissue has accidentally been exposed to formalin. So sometimes accidentally it was dropped into the formalin container, pulled out and then put into Michelle's. We can actually tell that happened because then everything glows with the same intensity because there's a lot of cross-reactivity that happens from formalin exposure. And George also says, and I agree with him, that sometimes even when they're just so close together that there's like a lot of formalin fumes kind of around this non-fixed tissue. This tissue is not fixed, that sometimes everything can glow a little bit more. So just a little helpful hint, don't accidentally drop your IF tissue into the formalin. And now I'm going to show you the lambda light chain, which is our other IF that we really love. It's one of our most robust immunofluorescent stainings. It is looking at the light chain for all immunoglobulins. So not just IgG, but it would also, if there's IgM in here or if there's IgA in here, it's going to stain that as well because those all have light chains as well. Dogs and cats mostly make lambda light chain that is different than humans because humans have a higher ratio of kappa light chain than dogs do. So in humans, you would actually do a lambda light chain stain and a kappa light chain stain, and you would look at the difference between the two as well as one of your other diagnostic criteria. But because from what we have seen based on staining of lymph nodes, dogs and cats tend to make lambda light chain. And if there's a clinical pathologist who wants to do more flow cytometry to try to figure out why, that would be great. But we just use what we know from the literature. Okay, so I was able to text JD. Again, I did not put it in the report. I just said, hey, it's strongly positive. This is definitely a membranous. We'll do IF, and I'm pretty sure we're going to see deposits that are along capillary walls based on the history and the entire presentation with histology, the trichrome staining, etc. It was likely going to be deposits on the outside of the capillary loop. I will obviously at the end of getting the IF, or sorry, the EM back when we get it back, give you guys an update just to make sure. And then what ended up happening with the case?
So the ascites and the edema actually significantly improved to the point where the male owner asked if I could give him anabolic steroids because he was so skinny and had no muscle anymore. And I said, not right now, no. But unfortunately, so we sent him home on 1.5 mg per kg per day of pred, on like a 10 mg per kg per day Q12 dose of mycophenolate, and then I think like a mg per kg of telmisartan, with plans to taper the steroids over the next like 2 to 3 weeks. When he was about at 0.5 mg per kg per day on the pred, the owner noted that his appetite was starting to decrease, and she was worried that he was starting to have some melanotic stool. I had them come back and recheck some like kidney values and electrolytes, and his creatinine was still 1.4, so it never changed from 1.4, but his BUN doubled. It went from 20 to 45. Initially, I had her just completely stop the steroids at that point, And then over the following week, he was essentially just pooping straight blood. He started to vomit, and there was a hemorrhagic component to that. Our plan had been to, and I had her, when he wouldn't eat, I had her not give the medications. So he hadn't received like any telmisartan for a few days, and he'd only received a couple doses of the mycophenolate. Our plan had been to think about switching him to an alternative immunosuppressive that was maybe a little bit more GI friendly, maybe something like cyclophosphamide. But unfortunately, he continued to decline, and she took him into the RDVM and had him euthanized. And it sounds like he was extremely anemic. She said that he was like, all of his gums were very pale and he was not moving very much at that point. But he didn't have any more edema or ascites. So I guess with the one caveat being that like a few days after we stopped the pred, she'd noticed a little bit of fluid coming back into his legs. But yeah, so we'd had hope because he was not on Plavix. He was gonna start it maybe in like a week or so, but we hadn't started it yet because of the recent biopsies. So our hope had been, because he was a relatively young dog and because he was not azotemic and he had such good looking kidneys otherwise, if we could just get him through his GI bleeding, that he had a good long-term outcome. But we did not get him through that. So,
And it sounds like they didn't do histology or any kind of samples post-mortem.
Unfortunately not. If they'd come here, I would have grabbed some samples, but
yeah. I mean, so and we've talked about this a lot because I get a lot of questions from clinicians that I then refer to JD about the GI effects of mycophenolate. But this seems does this seem extreme with that, like blood casts almost?
Yeah, my working theory was that his intestines were already unhappy from how edematous he was. Because I don't normally think of steroids on their own as like being particularly prone to causing ulcers, but potentially the combination of the steroids and like really edematous intestines, and maybe the mycophenolate wasn't helping very much either, caused him to form like either one very bad ulcer or multiple ulcers that took him out. The other, I still don't know if this is related or not, but he also started to develop some like skin wounds somewhere around like a superficial to maybe slightly deeper pyoderma. And I don't know how much of that was because he's a hairless dog, his skin is like not normal anyways, and like the significant amounts of edema that he had experienced had disrupted things, or if there was some other component to his disease that was also targeting his skin. I don't know. Didn't ever get to the bottom of that, and we never biopsied his skin.
In our really early study that Audrey Cook and I did 1 billion years ago, we looked at thromboembolic complications of these proteinuric dogs, and there were a lot of these animals that are a significant portion of the ones that had thromboembolic disease. I was impressed that they were GI, and so this animal may have developed a thrombus in his gut, infarcted a piece of gut that also could have caused the bleeding.
Yeah, I guess, I mean, so from my understanding, most of the time when the GI effects from immunosuppressive therapy, it's mostly just diarrhea. It's not hemorrhagic. Am I misinterpreting that?
Normally I expect just
Right.
the diarrhea.
Okay.
The blood was unexpected.
Okay. Yeah, it would have been great to have been able to see, even to know where if it was just a segmental ulcer or something like that. To kind of figure out what happened. It really is unfortunate that and then it's also like, what if he just had secondary HGE, like not secondary, what if he just also was a dog that had HGE or something like that? Like he was so unfortunate that he had so many things like pile up on top of each other. But yeah, I was very hopeful that it was a good kidney because there was no scarring, there was minimal inflammation. I think I saw one focus of inflammatory cells in the kidney. And so I was really positive and happy about this case. And then you emailed me last, or I guess over the weekend, and was like, I just want you to know this happened. So and I don't know what other clinicians on there, what would you, is there anything you guys would have tried to have done differently, or would you have switched to Cytoxan if the mycophenolate was superimposed on GI bleeding? Anything? A minute. Okay. Let's see. I think I have there you go. Yep. Sorry, I'm trying to join from two places.
My comment is more general. I can't point to something that was done or not done and say it should have been done differently. But looking at the kidney, this is I've said on other occasions that if I'm a dog and I have to have kidney disease, proteinuric kidney disease, I want this one. With what its name is and how it looks, because we've had dogs that have had this that have gotten well, if you will. Larry will remember a dog we had back in 2008 named Cooper Minton, who ended up being not even proteinuric and was similar in its magnitude of proteinuria and extensiveness of membranous, early membranous change and whatnot. So the difficulty with them is getting them through the extrarenal complications that attend this state of affairs when they come in. And as Larry's pointed out, the thing that is often and maybe most common, I have no statistics about it, but the thing that you worry about the most is some thromboembolic phenomenon in one way, shape, or form. And I've had them just, I had a dog I was treating. He just almost went home and fell dead with a pulmonary thromboembolism. And the possibility of the vascular component of thromboembolic disease that affected the gut, or that on top of other components. I mean, certainly he bled to death in his gut, right? But we don't know what the mechanism that led to the bleeding that remained so severe. But it's a tenuous period when they're, before they begin to turn around, and you can get them on all the drugs they need to be. But the biopsy results justify optimism for a successful outcome if we can manage them through the worst of the disease, stop them getting worse, and begin getting them better. They have an optimistic outcome.
Is there any understanding from Friendship's part what the underlying disease might have been? What kind of, was there any infectious likelihood or other systemic disease that could have precipitated this immune-mediated glomerular injury?
He was 4DX negative. We had talked about sending out some other like infectious disease panels, but didn't when he was in hospital and didn't get around to it before he died. I think someone who was visiting mentioned that you can see like leishmania in Peru. We didn't test for it. I talked to the owners about drawing some blood for it, but I guess I would have hoped that maybe we would have seen that in the biopsies. Otherwise, we didn't have and I don't know, maybe there was something in his history we just didn't know about because it was kind of just a black box behind prior to the month or two the owners had him.
It's always a
Usually-
black box.
Usually leishmania is more hypercellular. It's not always, but it's usually. I hope you guys can hear me because now I switched to a different laptop. Okay. Usually it is more of a membranoproliferative pattern. It doesn't have to be. It can just be immune complex. But it almost to us, oftentimes when we see leishmania from Europe associated with GN, it's usually it kind of resembles Lyme nephropathy for what we see here. So, but that doesn't rule it out. But yeah, he is also just a very, interesting breed with no fur. Any other questions, comments from the clinicians or anything like that? We have about 8 minutes. I can show a GWiz if we want to. That's why I'm switching computers. But I don't have to show a GWiz if I don't need to.
I have a quick question for those who are involved in therapeutic plasma exchange. In people, there's like kind of flurries of case reports as far as using plasma exchange for people with a variety of different IGNs, and I was wondering, particularly because this dog was seen at Friendship, if that had come up as a potential, given how acutely sick and seeing how those kidneys looked. And I don't know exactly all the timelines here, but would that have been something as far as to really reverse this process pretty quickly and give the kidneys time to recover?
Well, maybe I'll comment because I think that's an area that we need to explore. We've looked casually at Lyme-associated nephritis in dogs that were getting plasma exchange, and we have some mixed results. But we have some where the proteinuria, so you'd have an animal with a very rapidly progressing azotemia, severe proteinuria, you do a plasma exchange, and all of a sudden the next day the proteinuria is resolved and the creatinine starts to drop. That's really confusing to me because you still have all the lesions in the glomerulus that you haven't resolved with plasma exchange. And so it makes me feel that there's some other gradu or some other stuff that you're removing from the plasma that had a role in the manifestations of the proteinuria and the perm selectivity, whether that's complement or modifying complement concentrations or some other manifestation of the inflammatory process. I'm not sure, but that's an area that I think would be very fruitful for us to look at as as another possible avenue to manage the acute manifestations, the fulminant manifestations of these severely proteinuric diseases.
Okay. And you guys, was that on the possibility, Dr. Skinner, or? We hadn't talked about it. And I don't know if in his particular case, he went downhill. He was dead probably like within 2 weeks of us seeing him. And for the first 5 days was extremely BAR, and then it kind of very rapidly went downhill from there. So, and I think like with him in particular, it was more his like, I don't know how much the TPE would have helped with like all the GI manifestations that we were seeing, which was causing him the most issues as opposed to like his kidneys.
I think the AR-10 would have been at the beginning, particularly an animal that has like the Lyme-associated diseases. I mean, those dogs are dead in days to weeks, and if you could intervene there before your drug therapy has a chance to work, that's where I think there could be a possible role.
Okay, I will quickly show a GWiz because it's only going to take about 2 minutes. This is actually a bladder sample. It's probably why I'm going to show it, because I want to show you guys something other than kidney. I'm doing so many more bladders. This is a bladder from what it ended up being was
a ectopic ureter surgery. It had been done many years ago, and they don't think that the implantation went correctly. And so, but nobody really noticed for many years because the other kidney was functioning and doing fine. And so they eventually realized that there was difficulty urination, and so they repeated an ultrasound many years later. And what they saw was a diverticulum from kind of where the ectopic ureter, it was almost like a nubbin. Like if you think about it, was only, imagine it was only partially resected. And I'm 99% sure when they did the ectopic ureter, because it was so badly ectopic that they had to remove the kidney as well. So I don't have the actual history in front of me, but so then when they basically removed the kidney and removed the ectopic ureter, there was a little nubbin that they left kind of projecting from the urinary bladder, and it continued to get enlarged and mildly inflamed. And then eventually they dog represented with abnormal urination patterns and hematuria. And then they found on ultrasound that they had this little dilated region. So they went through and removed all that. And so you can see that it's still lined by urothelium. It's got a little bit of mild inflammation as well below the urothelium in that lamina propria area. The reason I'm showing it is kind of what you got this perspective of at the first image, is that there is a bone in here. There is a very large plate of bone. It actually looks like pretty good normal bone. I mean, it's definitely being laid down by osteoblasts, but the spicules themselves don't look all that abnormal. It looks like it's just almost like endochondral ossification level, where it is starting to organize like normal bone and mineralize like normal bone, so that by the time you got to the edge, this looks like pretty good normal bone out there. So this was just a very interesting metaplastic response that happened from this previous surgery many years ago. And I just thought it was a kind of a cool gee whiz lesion. We have areas where it is kind of fragmenting, and we have inflammation within these spaces. This even actually could be some degree of myelopoiesis in here, so we might be actually having true marrow as well. But they removed that whole area, so I think the dog did very well afterwards. But just thought it was kind of a gee whiz fact that when you have really bad scar tissue, and if it's that common and that prominent, and maybe there was suture material in here or something like that, that was a nidus for chronic inflammation and chronic infection, that you can develop bone in your urinary bladder. I've seen bone develop also in kidney. The problem with that is that there's old literature that says once you see bone and cartilage in a kidney, then it has to be dysplastic. And I don't believe that's true. I think it can be metaplastic or a scar response where you have bone proliferation. So I think that seeing bone in the kidney does not make me immediately think that the kidney was maldeveloped or dysplastic. I usually look and see if there's a reason that there would be chronic scar tissue. Any questions about that case? I see, at least you could see it because I got a little crazy face on the chat. So at least you guys were able to see my images. Okay, well, I got that gee whiz out of I have just like a long list of gee whizzes. Oh, and they've actually been osseous metaplasia, huh? And were they in the pelvis, or were they kind of almost embedded in the urinary bladder? Oh, okay, interesting. Okay, so they actually were true like uroliths that were being urinated out, and they were true like little nubbins of bone. Interesting. Okay, so we can resume next month. I will send out a case request as well, and then we'll continue through my little list of all these gee whiz cases that take about 5 minutes to present. So okay, thanks guys for joining, and we're ending right on time, so I'm going to end the meeting.
Thank you.
Thanks.
Bye.